Hello guys, welcome to your own clinical YouTube channel. Today we'll be discussing about DLCO or DLCO and KCO, which is transfer factor for carbon monoxide. This topic is important for conceptual point of view, diagnosing various pulmonary conditions. Also, from MCQ point of view, it is really important for NEET or NEET SS or MRCP. So let us start. So basically, DLCO is equal to DLCO. This is basically the same entity, which is uptake of a substance against a pressure gradient. Okay. So when we determine it, we use a test gas, which is 0.3% carbon monoxide. Okay. So after maximal expiration, patient is asked to inhale this test gas to total lung capacity, then breath hold for 10 seconds, and patient is asked to exhale forcefully to residual volume, right? Sometimes a 10% of helium is added in order to determine the alveolar volume. Hope you are clear. So now we get DLCO is equals to carbon monoxide uptake divided by CO pressure gradient. So uptake is basically the quantity inhaled minus the quantity exhaled, because the inhaled quantity we already know and the exhaled quantity we do estimate, and the carbon monoxide gradient, that is the difference between carbon monoxide concentration in alveoli minus carbon monoxide concentration in arterial sample. So as we know, it is almost 100% bound to hemoglobin. So partial pressure of carbon monoxide in the blood is nearly zero. So this equation becomes quantity inhaled minus quantity exhaled divided by carbon monoxide concentration at alveolar level, which we have supplied. Okay, so this is the basic equation. So what are the factors which determine the DLCO? What are the factors which affect this entity? So from basic principle of diffusion, let us consider this is a membrane. From site A to site B, a substance is diffusing, right? So more the surface area, more the diffusion. So diffusion is directly proportional to the surface area. Then let us consider del P is the pressure gradient between these two sides. Okay, so more is the pressure gradient, more is the diffusion, so pressure difference is also directly proportional. Then comes solubility. The more soluble is a substance, more chance of diffusion, so it is also directly proportional to the solubility. Then thickness, thickness of the membrane, let us consider it H or T, we can say. So if the membrane is more thick, then the diffusion will be less, so it is inversely proportional. That means when the membrane is thin, the diffusion will be more, and vice versa. Also, another factor is molecular weight of the substance. It is inversely proportional to the square root of molecular weight. Hope you are clear about the concept. So now let us discuss the clinically important parameters which are helpful. So the conditions in which we get low DLCO. So basically two factors affect the value. First is perfusion. If there is decreased perfusion by any means, we will get a low DLCO value. And the second factor is diffusion abnormality, right? One is perfusion and second is diffusion, which is related to effective surface area. Got it? So let us consider a first condition, congestive heart failure. Here mostly due to systolic failure there is congestion and the DLCO is decreased. Secondly, in pulmonary arterial hypertension, DLCO value is lowered. In case of any damage to pulmonary artery, for example in SLE or systemic sclerosis, in this condition DLCO is also reduced. Then in pulmonary thromboembolism or DVT, they also lead to decrease in DLCO. These all factors contribute to decreased DLCO due to reduction in perfusion. And the fifth one is anemia. So the low SP, so low transfer, so decrease in DLCO. Clear? So now factors related to diffusion abnormality or decrease in surface area. First is, we can say, intrinsic restrictive lung stages. For example, bleomycin or nitrofurantoin or amiodarone therapy chronic or methotrexate leading to pulmonary fibrosis. So basically patients on bleomycin and chronic amiodarone therapy, there is an MCQ which is, what is the earliest sign of bleomycin toxicity? Earliest sign of bleomycin toxicity, that is decrease in DLCO. Got it? Okay. So these drugs affect the diffusion process, decreasing the effective surface area for diffusion, so leading to a decrease in DLCO. Got it? Then COPD. COPD basically divided into two entities. First is bronchiectatic component and second is predominant emphysema component. When there is predominant emphysema component, there is basically alveolar destruction and decreased DLCO. But if the bronchiectatic component is predominant, DLCO is normal. Point to remember in COPD patients. Okay. So then we will switch to the various conditions affecting a increase in DLCO. So in any condition which causes increase in perfusion will result in an increase in DLCO, because there is no condition which affects surface area or rise in surface area. So in left to right shunt there can be pulmonary hyperemia leading to increased DLCO. Second, alveolar hemorrhage. For example, good posture or also in pulmonary hemorrhage, okay, SB fraction increases, more RBC, so more diffusion. Hope you are clear. Okay, so now in asthma, not in early stages of asthma but in severe and chronic, due to two factors. First, there is a concept of neovascularization, which is VEGF mediated, which is same as the diabetic retinopathy component in chronic diabetic patients, and the neovascularization there in retina is mediated by vascular endothelial growth factor, which is implicated in the same mechanism in severe asthma. Okay, so neovascularization, more HP or more RBC, more diffusion, that is rise in DLCO. Also, some papers say due to increase in bronchodilators. So these two factors contribute to a rise in DLCO in chronic severe asthma patients. Okay, so also in patients with blood transfusion or erythrocytosis, can have a rise in DLCO. So the conditions in which we can get normal DLCO, right? For example, in patients with extrinsic restrictive lungs disease like kyphoscoliosis, rib cage defect, or neuromuscular disease. Okay, so these things are really important for MCQ point of views, and DLCO or TLCO, this is a very important topic for MRCP examiners. They are really fond of this topic. Also, along with the parameter, they ask questions regarding the transfer factor, expressed as KCO, also called transfer factor for carbon monoxide, right? Which is basically defined as the DLCO divided by alveolar volume. Important topic for AMRCP, both part 1 and part 2. Okay, they do ask questions in such a manner like among the among the available conditions, in which condition there is a increase in KCO and decrease or normal TLCO. They ask questions in such a manner, right? So as we have got the equation, KCO is equals to the DLCO divided by alveolar volume. So in any condition in which DLCO is either normal or mildly decreased, but the alveolar volume which is decreased significantly, in these conditions KCO value or the transfer factor value can be higher. For example, pneumonectomy or lobectomy, right? Ankylosing spondylitis or neuromuscular weakness, right? Also in kyphoscoliosis. In these conditions, there is a rise in transfer factor or KCO and normal or slight decrease in DLCO. These questions are asked frequently in MRCP and MCQ for NEET, I mean, or DNBSS or NEET SS examinations. Okay, so this is just a brief revision regarding DLCO and transfer factors on from the point of MCQs asked in various examinations. Okay, so read more about it. Thank you.